Dr. Baliga here. This podcast is on whether Eculizumab, a complement inhibitor, is beneficial in COVID syndrome. Is derived from an outstanding article titled "Will Complement Inhibition Be the New Target for Treating COVID-19 Related Systemic Thrombosis?" And this provocative article is co-authored by two of my colleagues at the Ohio State University Wexner Medical Center, Columbus, Ohio. The authors are Dr. Courtney Campbell, MD, PhD, and Dr. Rami Kawash, MD. They had recently published in mid-March an article in the European Heart Journal where they report that utilization of Eculizumab, a complement inhibitor, in atypical hemolytic syndrome can be beneficial. They review the literature in other coronavirus infections, particularly SARS and MERS COVID infection, and noticed in murine models that there was excessive complement activation. This excessive complement activation leads to diffuse thrombotic microangiopathy, TMA, and end organ dysfunction. In mouse models, blocking complement 5A with a murine antibody elevated lung and spleen damage with a decreased cytokine response and viral replication. Similarly, in atypical hemolytic uremic syndrome, utilizing complement 5 inhibitor, Eculizumab, when given early, has been shown to reverse both renal and cardiac dysfunction. Prior to the introduction of Eculizumab, the prognosis of atypical hemolytic uremic syndrome was poor, with 67% of the adults dying within 5 years. Thrombotic microangiopathy associated with transplants is also thought to be initiated by excessive complement activation triggered by endothelial injury from chemotherapy, radiation, or viral infection. One recent study showed that 78% of the patients with transplant-associated thrombotic microangiopathy had a pathogenic or likely pathogenic variant in complement-associated genes. More importantly, endothelial injury is a hallmark of COVID-19. Like SARS COVID infection, COVID-19 acts primarily through the ACE2 receptor, which is expressed widely in vascular tissues, including alveolar epithelium and cardiac pericytes. Complement inhibition may be a promising therapy for severe COVID-19 infection, Dr. Campbell and Dr. Kawash write in this Circulation paper, which was published in early April. And they say it does so by reducing the innate immune-mediated consequences of severe coronavirus infection, and this therapy would pair well with direct antiviral therapy. They argue that the published clinical observations of severe COVID-19 are consistent with excessive complement activation, which includes elevated LDH, elevated D-dimer, and elevated bilirubin, decreased platelet count, mild anemia, cardiac and renal injury, and reportedly diffuse thrombotic microangiopathy. Patients with severe and fatal cases of COVID-19 may have an increased susceptibility to thrombotic microangiopathy through a genetic predisposition to pathogenic complement activation, they go on to say. Complement inhibition was associated with favorable outcomes in SARS and MERS murine models and reversed cardiac dysfunction in atypical hemolytic syndrome thrombotic microangiopathy, which mimics the pathological findings seen in COVID-19. They suggest that complement inhibition may be a new target in treating COVID-19 related systemic thrombosis, and this approach is worthy of further investigation in randomized clinical trials. Independently, Dr. Tom Pitts from the Hudson Medical Center proposed a similar treatment for COVID-19 infection, that is Eculizumab. He brings his expertise treating immunological diseases which affect the nervous system, including myasthenia gravis, Guillain-Barré syndrome, and multiple sclerosis. According to the website of the Hudson Medical Center, where Dr. Tom Pitts works, he had spoken to the FDA and was invited to trial this medication under emergency approval on a case-by-case basis. His proposal was being reviewed by the Coronavirus Group, which is a multi-agency task force which reviews potential therapies with COVID-19, including the FDA and CDC, among others. His study was registered in clinicaltrials.gov in late February. There are two other studies registered on clinicaltrials.gov evaluating Eculizumab in COVID-19 infection from France. According to Alexion, the pharmaceutical which manufactures Eculizumab, they on 7th of April had a press release which showed that they plan to start evaluating Eculizumab in COVID-19 phase 2 trials soon. If the phase 2 trial, which includes 100 patients, delivers a positive benefit-risk ratio, it would then pave the way for a 300-patient randomized trial that would start shortly after. The phase 2 COVID-19 trial will have sites in the US and Europe and is targeted to run for 2 weeks. The trial will have a primary endpoint looking into patient mortality between 3 to 4 weeks. The study is on the heels of a 10-patient single-site proof-of-concept trial which started about 10 days before the press release in early April. The company is providing Eculizumab for experimental emergency therapy for a small number of patients with COVID-19 infection and severe pneumonia, it states in this press release. Another important paper in this field is by Lisa Gralinsky in the American Society for Microbiology journal, MBio, titled Complement Activation Contributes to Severe Acute Respiratory Distress Syndrome, Coronavirus Pathogenesis. So if indeed complement activation is an important mediator of severe ARDS, associated coronavirus, then hopefully using Eculizumab, which inhibits the complement system, should be beneficial. Kudos to Dr. Courtney Campbell and Dr. Rami Kawash for connecting the dots between their earlier publication and the COVID epidemic. Stand by for the results of the phase 2 trials as announced by the company which makes Eculizumab.